Sir, my patient is a 46-year-old lady, a housewife by occupation, resident of Alwar, Rajasthan. She came with a chief complaint of abdominal lump in the left upper quadrant since 20 years. History of presenting illness. My patient was apparently all right 20 years back when she noticed a lump in her left upper abdomen, which was insidious in onset, painless, small, of a size of a ball just below the margin of the left ribs, which gradually increased to the present size, reaching up to the umbilicus. For the past 5 years, patient has been having dragging sensation with heaviness over the lump. For past 1 year, she's been having postprandial fullness and early satiety. She gives history of single episode of hematemesis 5 years back, which was spontaneous of a quantity of approximately 100 ml, painless, fresh, containing fresh bloods without any clots, not associated with melena or retching, for which patient visited a local practitioner and was managed conservatively and was relieved of her complaints. There was no history of any hospitalization. She gives history of fatigue, shortness of breath, and generalized weakness since 5 years. Patient also gives history of intermittent fever of low grade, not associated with chills and rigor, lasting for 2 to 3 days, managed conservatively with oral medications since last 2 years, occurring once in 2 to 3 months. The last episode of fever was about 2 weeks back, for which she was admitted in a nursing home and was managed with IV fluids and 2 units of platelet transfusion given in the same admission. There was no history of epistaxis, gum bleed, or easy bruisability in the past. No history of any blood transfusion in the past or any endoscopic intervention. No history of alcoholism or no history of any viral hepatitis. There's no history of abdominal distension, jaundice, drowsiness, and altered consciousness. No history of hematuria or urinary symptoms. No history of constipation or altered bowel habits. No history of night sweats or fever with chills. No history of swelling in the neck, axilla, or groin. And there's no history of any oral contraceptive pill intake. She doesn't have any history of tuberculosis, diabetes mellitus, hypertension, or any past surgical history. She was born with by normal vaginal delivery at home with normal developmental milestones. Menstrual and obstetric history. Her menarche was at the age of 14 years with regular cycles, and she has attained menopause 6 months back. She is P3L3A0 with normal vaginal delivery at home. Her personal history, she consumes mixed diet, sleep is good, normal appetite and stable weight. Bowel and bladder habits are regular. Family history is not significant. Summarizing, my patient is a 46-year-old lady with no comorbidities, with painless, gradually progressive lump in her left upper abdomen since 20 years, associated with dragging sensation, with heaviness over the lump, and generalized weakness since 5 years, and early satiety since 1 year. Patient also gives history of 1 episode of self-limiting small quantity hematemesis 5 years back, and intermittent episodes of low-grade fever since 2 years, with last episodes 2 weeks back requiring hospitalization and 2 units of platelet transfusion. So my differential diagnosis.
So before we come to the differential diagnosis part, right? So
Yes,
what do you think? What is going on? What is the pathology you are dealing with?
Sir, patient is complaining of an abdominal lump since 20 years. So she gives a long history of abdominal lump, and it is a slow growing lump in size. And she started developing symptoms because of the lump since past 5 years in terms of dragging sensation and heaviness. And she's giving 1 episode of small quantity of hematemesis. So I want to think in terms, depending upon the location, I want to think of it to be a splenomegaly and hematemesis. So I'm thinking in terms of portal hypertension.
This generalized weakness.
Yeah. So generalized.
What would be the cause of the generalized weakness?
Sir, cause of generalized weakness could be anemia, sir.
And then what do you think? What could be the cause of or indication for this platelet transfer? Is it required for fever? Because patient got admitted for the fever complaint, right?
Yes, sir.
And she has been having intermittent low-grade fever for the past 2
Yes,
weeks.
sir.
So what do you think, what was the indication for platelet transfusion?
Sir, patient is giving history that she was admitted in a nursing home and they did certain set of blood investigations and the platelet was found to be low in quantity, and that is why they transfused platelets. But
what would be the cause of fever?
So cause
what is the common scenario in which you have a fever with thrombocytopenia requiring platelet transfusion?
Sir, it could be dengue, sir.
Yes. So, but in this patient, what do you think?
So, sir, this
What could be
patient
the cause of fever? And platelet transfusion, you mentioned that indication was the thrombocytopenia.
sir,
What?
she's giving history of intermittent low-grade fever, sir. So there is history of multiple infections in the past. So it could indicate leukopenia, sir.
Multiple infections in the past. How can you say this? What is there in the history part which suggests that patient is having multiple episodes of infection in the past? I think you
Uh,
have not mentioned this in your history part.
um,
Niranjan,
yes,
may I
sir.
interrupt, sir? Just 1 second.
Sure, sir. Please.
Uh, what do you think, sir, is trying to hint you towards? Leukopenia, platelet reduction. What is the cause for that you are thinking?
So, sir, I'm thinking in terms of it could be a symptomatic hypersplenism, sir.
Okay. So, in symptomatic hypersplenism, is there lack of immunity?
No, sir. Per se, immunity is preserved. There is seen a reduction in WBC counts, sir.
Though that is seen, they don't have immunosuppression.
Yes, sir.
Yeah, they only manifest leukopenia and thrombocytopenia, but the thrombocytopenia and the leukopenia are rarely the cause for symptoms.
Yes, sir.
Anemia is the cause for symptoms, and you can think of hypersplenism if two or more elements are abnormal. More than one element abnormal is the definition.
Yes, sir.
So if you have two elements, then you can say that she has hypersplenism.
Yes,
Leukopenia you cannot say, but pallor you can see,
yes.
and you can ask for petechiae, ecchymosis. Does she have any symptoms? Though she's unlikely to have all those things.
No,
It's
sir.
very different when a hematological cause is the cause for splenomegaly, where they will be symptomatically abnormal.
Yes, sir.
So in hypersplenism, because of portal hypertension, they don't have immunosuppression or platelet reduction induced bleeds.
Yes, sir.
So, in your opinion, was the 2 units of platelet transfusion wasted, or is it right procedure?
Sir, it was wasted, sir. It was of.
Yeah. What happens to platelets when they are transfused?
So, sir, if I mean, even if we transfuse platelets in a scenario where patient is having symptomatic hypersplenism, it is just going to be engulfed by the spleen and lyse. So it's not going to provide any as such benefit to the patient.
Yeah, I agree with you.
Right. So at this stage, you are just thinking that patient is having splenomegaly with hypersplenism,
Yes, sir.
and that is leading all the problems that she is having for the past 20 years. Right.
Yes.
Okay. So, why did you ask the history of viral hepatitis and oral contraceptive use?
Sir, I've asked history for viral hepatitis because further I wanted to I want to find out the etiology for portal hypertension. So it could be a cirrhotic liver cirrhosis leading to portal hypertension, and a common etiology for that is hepatitis B and C infections. So I want to just rule out this history.
So, how do you rule out viral hepatitis based on history part?
Yes, sir. So patient did not give any history of jaundice or painful episode in the left upper quadrant, right upper quadrant of the abdomen, along with fever and
No, no,
malaria.
you mentioned that you want to rule out any viral hepatitis as a cause of cirrhosis that has led to splenomegaly, right? So,
Yes,
how
sir.
do you rule out viral hepatitis from the history, through the history? What do you
Uh,
ask specifically
Does
in the
does
history part?
Niranjan, does viral hepatitis always cause jaundice?
no, sir.
Hepatitis C, does it always cause jaundice?
No,
Compared
sir.
to hepatitis B, how is hepatitis C?
Sir, hepatitis C presents as a chronic infection, and a lot of time it remains.
Silent.
It
These small episodes of fever that she is getting could be an indication of chronic active hepatitis
Yes,
becoming symptomatic.
yes,
So that's what you should have been telling us.
yes, sir. And based on history, I would like to also whether she had any high risk behavior or multiple episodes of blood transfusion in the past, which is again a risk factor, for transmission of hepatitis B and C viruses.
See, it may be superimposed also, right? Because patient is having a chronic problem. She
Yes,
might
sir.
have received multiple transfusion, and that transfusion can lead to,
Yes, sir.
right? But in the current scenario, I think with all the kind of screening, I think this net screening is available not only at the few center, but otherwise in general that risk is very low with the blood transfusion at present. It
Yes,
is the
sir.
unprotected sex and some other risk factors which might lead to
Yes, sir.
superimposed hepatitis infection. But what I am trying to ask you that how you can rule out viral hepatitis based on history, because there are hepatitis A to hepatitis C. So what is
Yes, sir.
there in the history part based on which you can categorically say that there is no history of viral hepatitis?
Sir, we can ask about the high risk behavior or promiscuity. Uh,
No, that are the risk factor.
yes, sir.
They are different. But what are the symptoms based on which you can say that patient might have viral hepatitis? Because at this stage, you have not gone through all the records.
Yes, sir.
Until unless patient has specifically told you that I was diagnosed with so and so hepatitis based on certain investigations.
Sir,
Right?
Sir, I have directly asked her a leading question whether she was told by the practitioner or whether she had received any treatment for hepatitis in terms directly. After that, I have also asked the patient whether she had any episode of fever, malaise with abdominal pain. She has denied
So
that.
you can ask the patient about this by leading question only if the patient was investigated and was told about the
Yes,
diagnosis.
yes,
Right.
sir.
But that is a different thing. When you are asking about the history part, right? So, what are the symptoms based on which you will suspect that patient had viral hepatitis, whether it was a acute hepatitis or it was a chronic hepatitis? So, you want to rule out hepatitis A, E, which does not lead to cirrhosis, and you want to rule out hepatitis B or C, which in chronic phase can lead to cirrhosis.
Sir,
What is more relevant in this patient, given her overall symptomatology for the past 20 years?
yes, sir.
Which
Sir,
kind of hepatitis do you think is more relevant? Hepatitis A, E, or B or C?
Sir, B and C is more relevant in this scenario, sir, because they are known to have a chronicity and a progression towards cirrhosis. Hepatitis A and E usually present with a less dramatic course, although hepatitis
So,
E.
with chronic hepatitis B or C, what is the time frame for the development of cirrhosis and portal hypertension?
Sir, time period
How long
is
does it take for the chronic hepatitis to cause cirrhosis and then portal hypertension? Any rough idea? It is 5 years, 10 years, 15 years.
sir, it is approximately around 10 years, sir.
Okay. So it is about a decade, right? And patient is symptomatic for the past 20 years. He is 46 years old.
Yes, sir.
So she had symptom at the age of symptom onset at the age of 26 years, right?
Yes, sir.
So for the cirrhosis to develop, she might have got infected if it is because we don't know about the cause of this splenomegaly or portal hypertension at this stage, right?
Yes, sir.
So it must be that she had cirrhosis, portal hypertension at the age of 26.
26. Yes, sir.
Means she already had hepatitis B or C at the age of
16 years.
16 years or 15 years or maybe
Yes.
10 years. We don't know.
Yes, sir.
So is there a possibility? What could be the risk factor of such hepatitis B or C at that age in the child?
Sir, there is a perinatal transmission also, like there is vertical transmission also, which can, with hepatitis B.
So any history of pain abdomen, jaundice, prodromal symptoms kind
No,
of thing before the age of 10 or 15 years? No.
no, sir.
And what is the relevance of this oral contraceptive use?
Sir, oral contraceptive pill usage is linked with like procoagulant and hypercoagulable states that can lead to if we are thinking in terms of non-cirrhotic portal hypertension, so it is a risk factor.
What are the causes of other causes of hypercoagulability?
Sir, other causes of hypercoagulability are protein CS deficiencies, factor 5 Leiden deficiencies, APLA syndrome, SLEs.
Okay.
And,
Yeah, I joined a little late, so I missed the initial presentation. But based on this summary,
Yes, sir.
you should say that because the commonest lump in the left upper abdomen is spleen, so there is splenomegaly. There are features to suggest anemia, generalized weakness.
Yes, sir.
The history of platelet transfusion in this setting suggests that probably the platelet count was low.
Yes,
And now, since there is a history of one episode of hematemesis, yes, you have to keep portal hypertension in mind, but you also have to mention that small quantity hematemesis, self-limiting, not requiring transfusion 5 years back, and after that, no hematemesis, whether it was because of a low platelet count and unrelated. So, other than portal hypertension, you have to somewhere bring into discussion a hematological cause of splenomegaly and hypersplenism also.
Yes,
And
sir.
I hope that you mentioned the menstrual and the pregnancy history in detail, the obstetric history.
Yes, sir. Yes, sir.
Yes. Okay, please carry on.
right. Last point, the history part. What is the relevance of this home delivery part? You specifically mentioned that there was a history of home delivery.
Sir, home deliveries in the past used to be associated with umbilical sepsis, sir, because there was a common practice of application of dung over the umbilical stump. So it was, umbilical sepsis is also associated with development of non-cirrhotic portal hypertension. So I have asked that history.
Go ahead with the differential diagnosis.
So my differential diagnosis is portal hypertension bleeder, which is self-limiting with symptomatic splenomegaly and hypersplenism, likely due to non-cirrhotic portal hypertension and chronic liver disease.
Okay. So justify your diagnosis of portal.
Sir, I have framed a diagnosis of differential of portal hypertension because she's having history of hematemesis in the past. Along with that, she's having generalized weakness and history of platelet transfusion in the past. Along with that, she has a splenomegaly also. So I'm thinking in terms of portal hypertension.
Okay. So this is what I was saying. If this patient goes to a medical department, they will make a diagnosis of a hematological cause and put portal hypertension below that. So that is the bias. Yes,
See, there are key points here based on history, right? You are suspecting massive splenomegaly or at least moderate splenomegaly. There is a thrombocytopenia.
Yes, sir.
There is a history of upper GI bleed.
Yes,
And
sir.
you are suspecting leukopenia also because there is a history of chronic history of intermittent fever, right?
Yes.
So with these key points, what could be the differential diagnosis? Leave apart the portal hypertension. So you have a splenomegaly.
Yes.
You have upper GI bleed. You are suspecting anemia, thrombocytopenia, and leukopenia.
Yes, sir.
Right. So based on this point, these all key points, what could be the differential diagnosis? What could be the causes of these key combination of key points? One, you have mentioned portal hypertension. What could be the other causes of such presentation?
Sir, splenomegaly as such can be due to sir, can keep other causes of splenomegaly as well, like certain bleeding disorders because of hereditary
Certain bleeding disorder means?
Sorry, sir. I mean hematological disorders like hereditary spherocytosis or
why do you have thrombocytopenia and hereditary spherocytosis or upper GI bleed?
Hereditary spherocytosis is usually not associated with moderate or massive splenomegaly and almost never gives rise to hypersplenism.
Yes, sir.
In ITP and spherocytosis, spleen is usually small.
Yes, sir.
It is the other hemolytic disorders like thalassemia, CML, where the spleen can be moderate or massive.
Yes, sir.
And the other causes of a very large spleen are malaria and Kala Azar.
Yes, sir.
Yeah. Has it crossed the midline?
Yes, sir. It has reached up to
What
the
is the importance of crossing the midline of a left hypochondriac lump?
Sir, it indicates massive splenomegaly. So,
But you have not
What about
examined
renal
at this
lumps?
stage.
Do renal lumps cross the midline?
no, sir, renal lumps will not cross the midline.
Why not?
Sir, sir, because of sir, renal lumps will not usually cause midline because they are encapsulated with, there is a gerotas fascia.
Yeah.
Due to that,
So until you do your clinical examination at this stage in the clinical history, you can't even rule out renal lump. A large hydronephrotic lump can be there, and everything else might be incidental. A small episode of GI bleed, no melena, no significant hematemesis after that. 15 years she has been asymptomatic. So portal hypertension is very difficult to defend, except that spleen is the commonest enlargement, and any bleed you should consider portal hypertension. Other than those arguments, until you finish your clinical examination, you cannot tell us. And also, you have mentioned non-cirrhotic portal hypertension. What are the entities that come under that?
sir, EHPVO and NCPF are the two
Which is more
major.
likely in this case?
In this patient, non-cirrhotic portal fibrosis fits in, sir.
What are the
NCPF.
features are there of non-cirrhotic portal fibrosis?
So the age of onset for non-cirrhotic portal fibrosis is usually third and fourth decade, sir. So the presentation is that way. Also, patient
What
is.
about encephalopathy?
Sir, there is no encephalopathy in this case, sir. Like she does not have any history of heart
No, but
block.
if you're saying it's NCPF,
Yes, sir.
is it more likely to have encephalopathy that compared to EHPVO, or is it the same, or is it worse than cirrhosis, or how is it?
Sir, it is more in NCPF, sir. Encephalopathy is more seen in NCPF than in EHPVO.
Yeah, can you in EHPVO do you get such a large splenomegaly?
Sir, that is also a thing that NCPF will usually present with massive splenomegaly, and EHPVO will present with smaller, like mild to moderate splenomegaly.
No, they can also produce large massive spleens, and because of the long duration, they can produce it. Unless
Yes.
collaterals are formed and it decompresses, you
Yes.
can get a spleen which is enlarged in EHPVO as well. But like you say, it's more common in NCPF to have a moderate to massive enlargement of the spleen.
Yes, sir.
At this stage, you should have said that I think she has splenomegaly, she has hypersplenism. The possible causes in view of hematemesis, I would like to keep portal hypertension as first, but I can't rule out a hematological cause of splenomegaly and hypersplenism.
What is the difference between endemic malaria and sporadic malaria?
Sorry, sir.
They will have only low grade fever, small episodes of low grade fever, as compared to the classical chills and rigors fever of malaria. That's more common in a person who has gone to visit a malarial infested area and is coming from a population where there is very less malaria.
Yes, sir.
Otherwise, you can get a malarial spleen that is very large and has significant risk of rupture, and that's another important cause. It used to be called Banti spleen, which included NCPF and malaria. But you should remember malaria as a cause, Kala Azar as a cause. In
Yes.
India, you have to think of these reasons.
Yes, sir.
Where is Kala Azar more common?
Sir, Kala Azar is more common in certain parts of Bihar and West Bengal, sir.
Yeah, east coast of India is more common. Orissa, Bihar, and Andhra Pradesh and West Bengal. You're right. So Kala Azar you have to keep in mind, because you have to think of treatable causes. All causes of splenomegaly you should be able to list, because
Yes.
examiner will immediately ask you if you think it's splenomegaly, list the causes of splenomegaly, and you
Yes.
should have that list ready in mind.
Suppose I say, last point. Suppose I say it is not a splenomegaly. It is a large tumor, benign, relatively benign tumor like cyst arising from the stomach, and patient has ignored her symptoms. So, can you explain all these presentation, like lump in the left upper quadrant, hematemesis, one episode, apparently anemia?
Sir, yes, sir. This GIST can explain these symptoms with a long-standing mass. which can present in this manner.
How will you explain thrombocytopenia?
So thrombocytopenia cannot be explained.
Right. So you have to say this thing. Examiner can ask you anything, but you have to justify.
Yes, sir.
What are the more common points going in favor of one particular diagnosis? So please go ahead.
So general physical examination. She is a middle-aged lady, averagely built and moderately nourished, conscious, cooperative, and well-oriented to time, place, and person. Her height is 158 centimeters, weight is 56 kilograms, BMI is 22.4 kilogram per meter square, and her ECOG performance status is 1. Vitals, her pulse rate is 98 beats per minute, respiratory rate is 12 cycles per minute, BP is 108 by 60 millimeters of mercury, SpO2 is 99% on room air, breath holding time is 28 seconds. On general physical examination, pallor is present. There's no icterus, clubbing, cyanosis, lymphadenopathy in the neck, axilla, or groin, and there are no signs of liver cell failure. On per abdomen exam, on inspection, abdominal fullness is present in the left hypochondriac, left lumbar, and umbilical region. Flanks are free. Umbilicus is everted and pushed below in the right paramedian position. All quadrants move equally with respiration. No scars, sinuses, engorged veins, pulsations, or peristalsis present. No cough impulse present. There's no renal angle fullness, and external genitalia appears to be normal. On palpation, abdomen is soft and non-tender. There's no local rise of temperature. Spleen is enlarged and palpable, 10 centimeters below the costal margin along the long axis. It is firm, non-tender, extending up to the umbilicus. There is no other organomegaly. Hernial orifices appear to be normal. There is no renal angle tenderness and no fullness in the flanks. External genitalia appears to be normal. Percussion. Liver dullness starts in fifth intercostal space. Liver span is 12 centimeters at mid-clavicular line. Dull note is present over the spleen. Rest of the abdomen is present. And there is no evidence of free fluid. Auscultation, bowel sounds are normal, and there is no bruit or venous hum present. Digital rectal examination is normal. Other systemic examination, respiratory system, bilateral air entry is equal, and there are no adventitious sounds heard. CNS conscious oriented, and CVS S1, S2 is heard. So my summary is, my patient is a middle-aged lady with ECOG performance status 1, with painless, gradually progressive lump in the left upper abdomen since 20 years, associated with dragging sensation and heaviness over the lump since 5 years, and early satiety since 1 year. Patient also gives history of one episode of small, self-limiting small quantity of hematemesis 5 years back, multiple episodes of low-grade fever since 2 years, with last episode 2 weeks back, which was managed conservatively. On examination, she is having pallor with grade 3 splenomegaly, and there are no signs of liver cell failure.
It's not enough to say that digital rectal examination is normal. In a case like this, you should have added that the finger stall shows normal colored stool with no melena. In a patient with obstructive jaundice, you should say stool is colic or acolic. In a patient with suspected malignancy, you should say no rectovaginal or rectovesical nodule palpable. You have to give the important negative finding also.
Okay, sir.
And in the summary, I don't see the platelets here. You have missed that.
Yes, sir.
Same, I think in the abdominal examination, you have to mention the important negative findings. What about the any collaterals, tepid medusae, ascites?
Yes, sir. Yes, sir.
Are they relevant in the context of your splenomegaly?
Yes, sir, they are.
And what are the signs of liver cell failure that you mentioned or you specifically looked for? No signs of liver cell failure.
Sir, from head to toe, sir, patient will have icterus, malar erythema, parotid swelling, gynecomastia, spider nevi, Dupuytren's contracture, Terry's nails, koilonychia, abdominal distension, tender hepatomegaly, caput medusae or dilated anterior abdominal veins, pedal edema, testicular atrophy, and loss of axillary and pubic hair.
Caput medusae and dilated flank veins are not signs of liver cell failure. They are signs of portal hypertension. The two are different.
You didn't mention spider telangiectasia.
Yes, sir, spider nevi, yes.
Where do you look for them? How many are normal?
Sir, we'll normally see them on the Chest, sir.
Is there
Chest
some
was.
area or only chest? Some area, what distribution, which vein?
Can you look for them while patient is in supine position? You have to change the position. I think if you look for them in the upper back and the chest.
I think it is the upper part of the anterior chest. Rajendra, am I right?
It's superior vena cava distribution, sir,
Okay.
and most commonly seen in chest, back, and head and neck. What is the difference between spirotelangiectasia and darkly pigmented individuals and fair-skinned individuals? Was she dark-skinned or pale?
She was darkly.
Yeah, if she was dark, how will spirotelangiectasia appear in her as compared to a fair-skinned person? Okay, I'll tell you the answer. It is you will usually see only the central spot in dark-skinned individuals as a dark spot on the skin, and which is blanching on compression with a slide. So always examiner will ask you, do you have a glass slide with you? You should always have a glass slide with you because you have to press it and it has to blanch. Then it's a spirotelangiectasia, or it
Yes.
could be a Campbell De Morgan spot. That's one thing. And how many are normal in females? How many are normal in males? Do you know or don't know? 1 to 3 in males, more than 5 in females. And why is it more in females?
Sir, because of presence of estrogen, sir.
Yeah, estrogen is the cause for formation of spirotelangiectasia.
Vishal, carry on, please.
So now, what's your differential diagnosis after
Sir,
you have examined the patient?
Sir, on examination, my differential diagnosis is portal hypertension, bleeder, self-limiting with symptomatic splenomegaly and hypersplenism. And
Basically, same. Like,
pain.
so your examination did not make any difference in your differential diagnosis.
How can you calculate CTP score on examination only?
Sir, CTP, as such, I cannot comment on the CTP score directly, but
You have written that.
yes, sir.
You can say well compensated cirrhosis. That is a clinical assessment. But you
Yes.
can't say CTP is A.
Yes, sir.
I think it is better not to add any adjective at this stage. You simply mention like it is a non-cirrhotic portal hypertension.
Yes,
Then
sir.
it is a cirrhotic. So this is in terms of your priority. So first you are thinking of NCPH, right?
Yes, sir. Yes,
And
sir.
then cirrhotic. So
Yes, sir.
given in the NCPH, what is your first this thing? It is a NCPF or EHPPF? Which one is more likely?
In this case, NCPF is more likely than EHPV, sir.
NCPF is more likely. Then,
Yes.
so in terms of all the three entities, what is the number one NCPF? Number two, EHPPF. And the last is cirrhosis.
Yes, sir.
Can it be Budd-Chiari syndrome? Chronic Budd-Chiari syndrome?
Sir, she's not having hepatomegaly, tender hepatomegaly, sir. And
Is it chronic Budd-Chiari? I said chronic Budd-Chiari. Do you expect acute or subacute Budd-Chiari at this stage with a history of 20 years?
Sir, she doesn't have ascites as well. Not thinking in
But at the
terms.
same time, you have mentioned this cirrhosis compensated.
Yes,
What is
sir.
the presentation of chronic Budd-Chiari?
Sir,
I think they also have a same presentation like any other cirrhosis, except the etiology is different. So the portal hypertension, bleeder with symptomatic splenomegaly and hypersplenism. So first, you are thinking in the NCPF, non-cirrhotic portal fibrosis, then EHPV.
yes, sir.
So going back to the discussion, I think previously we have discussed this thing. Why you are thinking NCPF as the first?
Yes, sir. I'm thinking about NCPF first because the age of presentation of the patient, and she's presenting with a massive splenomegaly. She's a bleeder, which again points towards a portal hypertension with NCPF. Yes, sir. So,
In which condition your upper GI bleed is well tolerated? They are less severe and less frequent.
sir,
NCPF, EHPV, or cirrhosis?
Sir, cirrhosis will have will have the least amount of metamesis, sir. Their presentation will first present with ascites and those they will not present. Basically, they will not present with a bleeder. In between EHPVO and NCPF, EHPVO will present in first or second decade of life with a massive self-limiting hematemesis sometimes, and NCPF will present in the second or third decade.
I think you're incorrect when you say that cirrhosis cannot present as a signal bleed. It can present as a bleed, and it can be massive, and it can result in death. Encephalopathy is rare in cirrhosis, less common in NCPF, and least common in EHPVO. That is the only difference.
It is most tolerated in EHPV, right?
Yes, sir.
Because liver function is preserved.
Yes, sir.
NCPF in the end stage, they also behave like any other cirrhosis. So that is a problem. So NCPF, it can be a non-cirrhotic, non-nodular type, or it can be a cirrhotic or nodular type in the end stage. So ultimately, the NCPF behaves like a cirrhosis because liver function is finally affected. But in EHPVO, liver function is preserved. So bleeding is well tolerated.
Yes,
right? They recover very soon after the bleeding episodes. But in cirrhosis, what happens after the bleeding, the liver function deteriorates. So a well compensated cirrhosis can convert into a decompensated cirrhosis after an episode of upper GI. So you are thinking just in terms of portal hypertension at this stage. You are not thinking of any other differential diagnosis, any other hematological problem. No, malarial spleen. No.
Sir, we can keep in mind about other causes as well, like malaria or.
Can it be hematological problem going on for the last 20 years without any other manifestation?
It is less likely, but it can present, sir.
It can.
When Dr. Vishal asked you about NCPF and EHPVO, you started by saying splenomegaly, bleed, hypersplenism. All these three do not differentiate between EHPVO, NCPF, cirrhosis, or Budd-Chiari for that matter. They are all features of portal hypertension.
Yes,
you
sir.
have to say the age at onset. You have
Yes.
to say the liver functional status.
Yes, sir.
To some extent, you can use the argument how big is the spleen, but as has been pointed out, you can have massive spleens in all the three conditions.
Yes,
It is
sir.
only when you study hundreds of patients, you can say that spleen is bigger in EHPVO as compared to NCPF as compared to cirrhosis. But in a given case, moderate, massive spleen can be present in all the three conditions. So in this particular case, the problem seems to have started at the age of 26 years. Bleed has occurred at the age of 40 years. That is very unlikely with EHPVO. So EHPVO is virtually ruled out. Now,
Yes.
if you are considering portal hypertension and there are no features of, and this is another mistake which students make, that this is not cirrhosis because there are no features of liver cell failure, there is no history of hepatitis. That is not correct. If it is there, it supports a diagnosis. If it is not there, it can still be cirrhosis. It is impossible to differentiate between NCPF and well compensated cirrhosis on clinical grounds. It is only on investigations that you can do that.
Yes, sir.
But what
Yes.
is there any physical sign based on which you can say that this patient is having cirrhosis? Means it is a non-cirrhotic portal hypertension or cirrhotic portal hypertension? Is there any physical sign based on which you can say this thing?
Are there any peculiar physical signs of, say, EHPVO or of Budd-Chiari?
Or cirrhosis? What is caput medusae? Why does it develop?
Sir, caput medusae.
If caput medusae is present, so what do you think? What could be the cause of portal hypertension?
It can be due to IVC obstruction, sir.
Caput medusae. What is caput medusae? Where is it seen?
Sir, caput medusae is seen in cirrhosis, sir.
No. In which part of the body do you see caput medusae?
Sir, it is seen around the umbilicus. We see veins dilate.
So is it present in IVC obstruction?
No, sir. IVC obstruction, we'll see longitudinal veins in the lower part of the abdomen. Yes, sir.
Flank,
What
typically
part of the
flanks.
In the flank.
Flanks, yes, sir.
What about the filling of the veins and emptying of the veins? How will that be different in each of them?
Sir, filling of the veins will be from below above in IVC obstruction, sir.
Other causes? What about in caput medusae?
Sir, in caput medusae, sir, they will.
What do they represent?
Sir, it represents.
Why they appear? What is the mechanism?
Sir, there is portosystemic shunt, sir, which is why they appear in the umbilical region with the flow.
So can they present in EHPV?
No, sir, they will not present in EHPV.
Which vein is involved on the portal side in the formation of capillary?
Umbilical vein is there, sir.
Umbilical vein.
Yes, sir.
Where does the umbilical vein drain into?
We know, sir. Sir,
कहाँ जाती है जब हम लैप्रोटमी करते हैं, एक स्ट्रक्चर को डिवाइड करते हैं, कई बार उसको लाइगेट एंड डिवाइड करना पड़ता है. Where does it go?
Falciform ligament, sir.
Base of the falciform ligament पे जाती है. Where is the base of the falciform ligament going? Which
the ligament is, sir? The
ligament is the obliterated umbilical vein which lies in the free edge of the falciform ligament. The entire thing which hangs down from the parietes is the falciform ligament. The extreme tip at the free edge, which feels like a cord, which you have to ligate and divide because sometimes it may be patent, is the umbilical vein, and it drains into the left portal vein. So EHPVO mein the block is below that, proximal to that.
yes,
So
sir.
that is why there are no caput medusae in EHPVO. Vishal, please proceed.
So go ahead. How will you
Uh,
approach?
sir, I will do two sets of investigation, sir. One to get to the diagnosis, and one to assess the general condition of the patient. Sir, blood investigations, I will send CBC, LFT, peripheral blood smear.
So you don't want to review previous reports because patient got admitted earlier. He
Yes.
was transfused with the platelets.
Yes,
Isn't
sir.
it?
Yes, sir.
Yeah, I'm very happy that you mentioned peripheral blood smear. In all patients with splenomegaly, you must look at the peripheral blood smear. That's the only way that you can diagnose some of the hematological conditions.
Yes, sir. Sir, I will also like to get a viral marker done. Sir, in CBC, sir, HB is 9.2, TLC is 3.56, sir, and platelet.
Don't read, just give your interpretation of the report.
Patient is having pancytopenia, sir, in his CBC. Sir, this is the LFT. LFT is essentially normal, sir.
What is more important parameter in the LFT?
Sir, we have to see for bilirubin, sir.
And
Alkaline phosphatase, sir.
more important. See, it is the albumin, protein in albumin. Because
Yes.
one of the DD was your NCPF and cirrhosis.
Yes, sir.
So it is largely normal, right?
Is something missing here, which you would have liked to have also?
More
Sir,
important.
PTINR, sir.
Yeah, you should comment. If you are given a report and you don't think it is complete or it is adequate, you should comment on that so that I know that you know what is a complete LFT.
Yes, sir.
Especially in the setting of where you are suspecting a chronic liver disease, you have to include the INR. That is the second synthetic function of the liver.
Yes, sir. Sir, PTINR is also, I mean, prothrombin time is 17.9 seconds, sir. It is slightly elevated with INR of 1.36. And viral markers are negative. Sir, peripheral blood smear shows reduced count, sir, and it shows macrocytic normochromic anemia, sir. TLC is also reduced and platelet count is also reduced. So it also indicates towards pancytopenia.
But when you have macrocytosis, I will say it is vitamin B12 deficiency and it's not hypersplenism. Do you agree with me or you don't agree with me?
Sir, macrocytic cells indicate vitamin B12 deficiency. So
Why does that occur in hypersplenism or any cause for anemia for that matter? If there is increased hematopoiesis, patient is chronically anemic, there is exhaustion of the stores of iron between B12 and folate.
yes,
So
sir.
because they are reduced, dietary intake is inadequate.
Yes, sir.
Then they result in B12 deficiency anemia. It doesn't
Yes.
rule out hypersplenism. It only says that there is additional B12 deficiency anemia,
Yes.
B12 and folate deficiency anemia. What condition in cirrhosis can cause splenomegaly with a small spleen and pancytopenia? Not pancytopenia, sorry, anemia.
Sir,
What condition will you suspect?
sir, hemochromatosis can have such a presentation.
I'm more concerned with portal hypertensive gastropathy.
Yes, sir.
It presents with anemia as well. So you should be sure that you're not missing out portal hypertensive gastropathy, which can be present in all three conditions. It can be present in NCPF, it can be present in cirrhosis, and it can be
Yes.
present in EHPVO. The mechanisms are different, however.
Yes, sir.
Right, go ahead.
Sir, I have gotten an ultrasound abdomen done. So it shows liver is normal in size with 13.9 centimeter and altered in ecotexture. And there is no space occupying lesion. And hepatic veins and portal venous radical are normal. Portal vein is dilated with 17 mm in size, and spleen is grossly enlarged with dilated splenic vein and presence of multiple perisplenic collaterals. Left kidney is normal in size, although they have not commented about the renal vein.
So, what is the interpretation based on the ultrasound and investigation so far?
Sir, portal vein is forming and it is dilated and it has multiple collaterals. So, because there is formation of portal vein which is seen, we can essentially rule out EHPVO. Liver is
This
not.
ultrasound was combined with the doctor examination, or it is just
No,
routine ultrasound?
routine ultrasound abdomen plus pelvis.
So, what is your inference based on that investigation and ultrasound?
Sir, this ultrasound supports the diagnosis towards NCPF with portal hypertension. And
why specifically NCPF?
How does it rule out cirrhosis?
Sir, it does not rule out cirrhosis entirely because liver is altered in ecotexture. They have they have reported as liver altered in ecotexture. So we cannot completely rule out cirrhosis at this stage.
So again, the same thing. Unless there is something to suggest cirrhosis, you cannot differentiate between NCPF and cirrhosis based on ultrasound also. Suppose there was ascites, moderate ascites, I could have said that this favors cirrhosis. Suppose the liver was shrunken, I could have said cirrhosis. But if liver is normal and just showing altered ecotexture, it doesn't. So your answer should be that ultrasound confirms that this is portal hypertension, number one. Number two, it rules out EHPVO, but it cannot differentiate between NCPF and cirrhosis.
Yes, sir.
And I would have liked to know about the position of the left kidney and the size of the left renal vein. I said it confirms the diagnosis of portal hypertension, but you have to remember that that statement is partly correct, partly incorrect, because it is confirmed only when you see varices on endoscopy.
Yes, sir.
Yes.
Next, I have patient has also I have also gotten an upper GI endoscopy done, which shows a grade 3 varices in the gastroesophageal junction, and they have done band ligation along with that.
Grade varices. Please grade the varices. Grade 1, grade 2, grade 3, grade 4.
So grade 1 varices just involves linear veins which are seen. Grade 2 is less than varices occupying less than 1/3 of the esophageal lumen. Grade 3 is more than 1/3 of the esophageal lumen.
That's all. This is grade 1 to 3. So, any specific maneuver you do during endoscopy to detect grade 1? Or it is just linear?
Sir, we can do air insufflation, sir. After which the varices collapse and then they refill, sir.
What are red markings?
Sorry, sir.
What are red markings on varices in esophageal endoscopy? You can see one of them in the topmost photograph.
Yes, sir. So it indicates high risk bleeding, sir. Red.
Yeah, what are they? Cherry red spot, vein on vein.
There are some terms which endoscopists use.
Cherry red spots and red veil markings are having higher propensity to bleed.
And also varix on varix, which is what is present in the topmost photograph.
Yes, sir.
So, do you think this endoscopy report is complete?
No, sir. They have not commented about the whether there is any presence or absence of any gastric varices.
So, they have not mentioned on the stomach or duodenum, although they have seen till D2.
Yes, sir.
So, now what will you do?
Sir, presence of
yeah, it's 10
yes,
already. I think we can
Vishal,
wind up.
Anand wants to say something.
Just to add in the in case of non-cirrhotic portal hypertension, sir. Recently, a new terminology was given for this portosinusoidal vascular disorder. I will share this article. This is a review article. This term is used the PSVD,
Okay.
portosinusoidal vascular disorder. Other than EHPO patient, when the patient is having non-cirrhotic portal hypertension, and these patients have some histological abnormalities. If there is cirrhosis, then the diagnosis will be not included. Other than cirrhosis, the patient is having then included in the group of portosinusoidal disorder, and I will share this article in our group. So this is all for our presidents.
So can we close, Vishal and Rajen?
Sure, sir. It's already 10.
Yeah.
It's
Okay. Thank
we
you.
should have
Thank you.
another session on portal hypertension discussion.
Yes. So students, please send me a mail, vkkapoor.india@gmail.com. Write portal hypertension in the subject. I'll send you some more material on portal hypertension. Thank you, Vishal.